Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Newborn Screening Follow-Up, Preventing Morbidity and Mortality in Children with Congenital Hypothyroidism and Congenital Adrenal Hyperplasia. Our objectives today are to explore the pathophysiology of congenital hypothyroidism and congenital adrenal hyperplasia, evaluate criteria used to diagnose congenital hypothyroidism and congenital adrenal hyperplasia, discuss the value of repeating newborn screening versus performing serum testing in confirmation of diagnoses, illustrate the various presentations of congenital hypothyroidism and congenital adrenal hyperplasia through review of case studies, report the value of long-term follow-up care for patients diagnosed with congenital hypothyroidism and congenital adrenal hyperplasia, and describe the challenges associated with chronic care of these diagnoses. Address frequently asked questions regarding endocrinopathies associated with newborn screening, and review services offered by Children's of Alabama Department of Pediatric Endocrinology for care providers within the state of Alabama. If you have any questions about anything being discussed today, please call or email our faculty presenters during our live broadcast. The phone number and email addresses are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluations are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses for today's program. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is November 14th, 2013. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. The Alabama Department of Public Health is now charging viewers who are not employees, contract employees, or retirees of the Alabama Department of Public Health for CE certificates. Registration and participation in both our live and on-demand programs will continue to be available at no cost. More detailed information and specific instructions can be found on our website. So let's meet today's faculty presenters. Dr. Gail Mick and Leslie Pitts, both from the University of Alabama at Birmingham. Welcome, ladies.
Thank you.
We are so glad that you have taken time from your busy schedules to be with us today, and we're looking forward to hear more about your presentation.
Thank you. Thanks, Annie. We're going to start just exploring the pathophysiology of congenital hypothyroidism and congenital adrenal hyperplasia. So to start with, we know that congenital hypothyroidism is an inability of the thyroid gland to produce adequate T4 and T3. This presents in the newborn period, and often severe cases even are clinically silent in infants, and therefore newborn screening has become universally recommended and implemented to diagnose congenital hypothyroidism. We know that congenital hypothyroidism occurs in approximately 1 in 3 to 1 in 4,000 babies. This number has been hotly debated recently, with some states reporting that the incidence may be more common, up to maybe 1 in 1,200 for some states. We know that this is more common in the Hispanic population, and the question has been, is the incidence becoming more common because of improved screening, or is the diagnosis actually increasing? Approximately 85% of the cases are sporadic and thought to be due to thyroid dysgenesis or an abnormal thyroid anatomy, with the extreme case being an absent thyroid gland. Approximately 10% of the cases are due to dyshormonogenesis, which is just a defect in the hormone synthesis, often inherited in an autosomal recessive pattern. And then there's a small percentage due to central hypothyroidism, which is an inadequate TSH stimulation from the pituitary gland. And then finally, there's the rare cases of transient hypothyroidism that are secondary to transplacental passage of either maternal medications for Graves' disease or antithyroid antibodies. Okay, so this diagram basically just shows the feedback mechanism from the hypothalamus to the pituitary gland. The pituitary then produces TSH, or thyroid-stimulating hormone, which tells the thyroid gland to then produce T3 and T4. And in a normal patient, this should work in a feedback where normal production of T3, T4 then turns off the secretion of TSH by the pituitary. For congenital hypothyroidism, we don't have this feedback, and our TSH levels increase while the T4 levels decrease over time. We know that optimal thyroid hormone levels are critical for neurodevelopment in the newborn period, and that untreated congenital hypothyroidism can produce profound somatic and neurological delay. Congenital hypothyroidism is thought to be one of the most common preventable causes of mental retardation in the world, and we know that with newborn screening for congenital hypothyroidism, we are decreasing the health cost burden by screening and treating these patients. When treatment is initiated early, and the thought on that currently is within the first 14 days of life, and sustained with normal labs, it's believed that children can have normal developmental outcomes with congenital hypothyroidism. And this is a picture from an endocrinology text that just shows just how profound congenital hypothyroidism can be when untreated. This is a 17-year-old female that was untreated for congenital hypothyroidism. And you can see that her average height of a 3-year-old and her bone age is about 9 months old. So in addition to just the neurocognitive effects of congenital hypothyroidism, the somatic growth effects can be quite profound. Okay, I'm going to turn it over to Dr. Mick.
Okay, now we'll switch over to congenital adrenal hyperplasia, which is due to 21-hydroxylase deficiency. This is the second endocrine disorder that we screen for in newborn screens. It's a family of inherited disorders that affect the adrenal gland's ability to produce cortisol. 95% of all congenital adrenal hyperplasias are due to the 21-hydroxylase enzyme deficiency. These disorders are inherited as an autosomal recessive pattern due to genetic defects in genes in almost 100 different identified places. The reported incidence of congenital adrenal hyperplasia is from 1 in 5,000 to 1 in 15,000. It varies widely depending on the ethnic group where you look. The clinical presentation also varies from very mild forms to more severe forms that require immediate intervention in the newborn period. This schematic just shows you the inheritance pattern of a recessive disorder where both parents can be unaffected carriers, the father carrying one affected gene and a normal gene, and the mother carrying one affected gene given by the small r and a normal gene. The odds, therefore, of having an affected infant is 1 in 4, as illustrated by the orange figure on the right, which carries a recessive gene from both the father and the mother. The most common causes or forms of CAH due to 21-hydroxylase deficiency are the salt-wasting or salt-losing form. This is the most severe form, a simple virulizing form, and an attenuated or non-classical form. This schematic shows the location of the adrenal glands which are affected in CAH due to 21-hydroxylase deficiency. The classical salt-wasting CAH due to 21-hydroxylase deficiency is the most severe form. It causes an inability of the adrenal gland to produce both cortisol and aldosterone. This results in adrenal crisis and maximum secretion of adrenal androgens. There can be near total masculinization of the external female genitalia in females. This schematic is very helpful in trying to understand why in 21-hydroxylase deficiency there's a deficiency of cortisol and the salt-retaining hormone aldosterone, and yet an overproduction of androgens. If you consider that the precursor of all these steroid hormones in the adrenal gland is cholesterol, and the pituitary gland regulates the flow into the adrenal gland, you'll see that in CAH, due to a block in the production of cortisol and the salt-retaining hormone aldosterone, you might have different flow in each ebb. In a normal situation, you'll have equal parts of cortisol, salt-retaining hormone, and androgen. But when we have salt-wasting CAH, there is a block in the production of the salt-retaining hormone and the cortisol hormone that leads to excess flow coming out in the androgen pathway. As a consequence of this, female infants can be virilized while they're deficient both in cortisol and in the salt-retaining hormone aldosterone. The simple virilizing form of CAH is due to an incomplete or partial loss of 21-hydroxylase. This is really a milder form of the complete form I just mentioned, which has salt wasting. There's increase in the stimulating hormone ACTH with inadequate production of cortisol, but the salt-retaining hormone is preserved. In the simple virilizing form of CAH, there are increased levels of the cortisol precursor, 17-hydroxyprogesterone, and increased production of androgens with adequate productions of aldosterone. This leads to a situation where the female infant is slightly virilized but not salt wasting, so they may not present with an adrenal crisis. With the simple virilizing CAH, the increased androgen production due to the increased ACTH stimulation is due to a partial enzyme blockage, therefore. The simple virilizing 21-hydroxylase deficiency can have variable degrees of female masculinization at birth due to variable amounts of enzyme deficiency. The more deficient they are, the more steroid hormone will be diverted to androgen production, and the more virilized the child will be. If undiagnosed at birth, they can present with signs of puberty at a very early age or advanced somatic growth. This schematic shows the steroidgenesis pathway in the adrenal gland, where you can see that at the level of where it's marked 21 and highlighted in yellow, this is the deficiency in the 21-hydroxylase enzyme. This prevents conversion of progesterone to deoxycorticosterone in the aldosterone production and decrease in aldosterone production, as well as decreased conversion of 17-hydroxyprogesterone to deoxycortisol in the cortisol pathway. As you can see, as a consequence of these blocks, steroid precursors are shunted into androgen pathways, which are shown on the right, and there's an increase of androstenedione, testosterone, and other metabolites. The attenuated or non-classical form of CAH is simply a milder version of the other two forms we've just discussed. There is minimal amount of the 21-hydroxylase deficiency. In these patients, we don't have the profound virilization of the female external genitalia at birth because there are only small blocks in the production of cortisol and aldosterone, and therefore low levels of androgen production during in utero life. In the attenuated form of non-classical CAH, changes typically develop in girls during puberty due to the excess androgen production. You can see the development of hirsutism, severe acne, menstrual irregularity, or even small ovarian cysts are possible. The bottom line is that there is a tremendous variation in the presentation of non-classical CAH. Many of these disorders, because the enzyme deficiency is mild, are not detected on the newborn screen. Here is a schematic classically used in the diagnosis of all congenital adrenal hyperplasias. What we do is a cortrosine stimulation test where we measure baseline 17-hydroxyprogesterone levels, which is the precursor which accumulates in the blood, before and after stimulation with ACTH. And based on the values plotted on this graph, we can determine what subtype of congenital adrenal hyperplasia we're dealing with. From the normal value, which you can see the values are in the hundreds, both at baseline and stimulated, to carriers who may carry the gene defect but not be affected, to the non-classicals, which have slightly higher levels, probably under 10,000 and stimulating up to 10,000, to the full classic forms, which are both the salt-wasting and the virulizing, where levels of 17-hydroxyprogesterone can reach into the 30 and 50,000s.
Okay, so now we're going to shift over to talk about how we make the diagnosis of congenital hypothyroidism and CAH. In congenital hypothyroidism, state newborn screening is optimally performed at 2 to 4 days of age. This is because of the normal neonatal TSH surge that occurs during the first few hours of life. So we know that if a screen is drawn prior to the second day of life, often the TSH will be elevated, and it's hard to kind of weed out which one of these are diagnostic, and except in the cases of severe elevation of TSH. So it's best to make sure that the initial screen is done at the best time. We know that any screen that results in a high TSH and a low T4 are considered concerning for congenital hypothyroidism, and these screens will warrant further attention. So this diagram basically talks, at least to our Alabama protocols, for diagnosing congenital hypothyroidism and confirming that diagnosis. If your initial newborn screen shows an elevated TSH and a decreased total T4, we look then at the time of collection. Was the screen collected at less than 24 hours, or was it greater than 24 hours? And then, based on the time of collection, what were the results? Any screen that is collected at less than 24 hours with a TSH greater than 150, or a screen that's collected greater than 24 hours with a TSH greater than 40 are very concerning for disease. And so we recommend that that patient have serum testing done to confirm the diagnosis. On the opposite side of that, if the screen is less than 24 hours and greater than 25, which is the normal cutoff, but less than 150, or if the screen is done at greater than 1 day and is greater than 25 but less than 40, typically these patients can just have the repeat newborn screening done as recommended for a second screen to rule out disease. We want to talk a little bit about the benefits of serum testing versus repeating the newborn screen. The diagnostic tests for congenital hypothyroidism are serum, TSH, and free T4. These tests cost approximately $90 to $200 based on which lab you're doing them at. And with these results, you don't have the risk of an unsatisfactory result that you can sometimes get with a newborn screen. And for serum labs, they're typically resulted within 24 to 48 hours, which becomes really important in making the diagnosis when you're talking about not delaying the treatment. So our treatment goals with congenital hypothyroidism are to treat with levothyroxine or Synthroid at 10 to 15 micrograms per kilogram per day. There's a lot of research on if you should start this at just the 10 to 15 micrograms per kilogram per day, or if using a loading dose is best to go ahead and normalize the TSH faster. We do recommend using the tablet form only, and our recommendations currently are to crush the tablets and mix them with a small amount of breast milk or formula each morning. I wanted to talk a little bit more about this because previous recommendations with Synthroid and levothyroxine have discouraged using it with any sort of foods and things like that. And so sometimes that's a common misconception. We do believe that it's fine to mix it with a small amount of formula or breast milk. We know that it binds a good deal with high amounts of iron and soy and calcium. So if you have a patient that's on a higher dose of either of those things, maybe a multivitamin, something like that, you can have them mix it with a small amount of water and give it. but the liquid form of the medicine isn't recommended because of its variability, and we're not sure that the dosing is very consistent with it. So we do recommend doing just the tablet form.
And now we're going to switch over to congenital adrenal hyperplasia and issues related to making the diagnosis. With newborn screening for CAH, we're trying to diagnose children before they have an adrenal crisis and avoid death. This major benefit is largely in males who may evade detection until they present an adrenal crisis without newborn screening and early identification. Obviously, with females, because of the overproduction of androgens that we discussed in the pathophysiology, many severely affected females are going to have virilized external genitalia, and that may be an immediate tip-off to the diagnosis, though not always. One must realize that there's a moderately high rate of false positives among premature infants who are tested for congenital adrenal hyperplasia, and this is simply because the adrenal gland is not entirely formed and is immature, so there can be elevations and early production of some of these precursors simply because the adrenal gland can't process the enzymes completely due to what appears to be an enzyme deficiency, but it's really just an immaturity of the adrenal gland that it will resolve. Sometimes we'll have false negatives on newborn screening simply because we have mild variants, such as the non-classical form. But the newborn screening test was designed to detect those who are at risk for acute adrenal crisis in the newborn period. So, confirming the diagnosis of classical CAH, we do a newborn screening filter card test, and on that, they're measuring the 17-hydroxyprogesterone level. That's the immediate precursor that can't be converted in the pathway due to the absence of the 21-hydroxylase enzyme. Typical values in severe CAH will be values greater than 150. As we mentioned, a female may present with ambiguous genitalia or virilization of the external genitalia that will give a tip-off to the diagnosis. Another very important tip-off could be the presence of electrolyte disturbances. You can see hyponatremia, which is a low sodium value, or hyperkalemia, which is a high potassium value, as well as hypochloremia in male or female infants. This is a sign of emergent salt wasting and is very important to act on and identify. In response to noticing any of these findings, either an abnormal screen or findings on physical exam or in the electrolytes, it's important to confirm by getting an immediate serum 17-hydroxyprogesterone level. We advise this as opposed to repeating the newborn screen because it's a more rapid and accurate way to get at the diagnosis. Another option is to get a serum adrenal gland profile, which is going to measure all the steroid precursors in the adrenal gland. This can be important and may be recommended by the endocrinologist because of the 5% of CAH disorders that are due to enzyme blocks other than the main one, which is 21-hydroxylase that we're screening for. So what are some of the limitations of the newborn screen for congenital adrenal hyperplasia? It's not always possible to determine the subtype of CAH based on the screening test alone. Genotyping can sometimes be done, but our usual rule of thumb is where it's not necessary and treatment has commenced, we may delay that testing to later in life and follow up in endocrine clinic simply because it can be a lot of blood to do the analysis. As we mentioned, another limitation of our testing is that many of the mild non-classical forms will be missed. But that's a very controversial area on the goal of newborn screening. We may not be able to detect all the mild variants, but we certainly want to detect all the serious, severe, and salt-wasting versions of CAH so that we can prevent adrenal crisis and death. And as we mentioned, preterm infants tend to have higher 17-hydroxyprogesterone levels due to the immaturity of the adrenal cortex. Again, we'd like to emphasize that there is some controversy as whether, when you have an abnormal, whether you should repeat the newborn screening versus obtaining serum testing. We can do repeat testing, and that may be required for abnormal results, but one of the problems with doing that is it can delay the diagnosis because it's a little more cumbersome in turning around. It also can take longer to get results, and it may not resolve problems in premature infants because there can be cross-reactivity with other steroid metabolites that are elevated in the premature infants simply because of the immature gland. Therefore, we recommend serum testing. And again, the metabolite you want to measure, if you have an infant that you question whether they have congenital adrenal hyperplasia due to the 21-hydroxylase deficiency, is a serum 17-hydroxyprogesterone level. This is easily attained through any of the commercial labs that most hospitals are connected with. The cost is roughly about $50, and it provides more accurate information, particularly related to gestational age and weight. We frequently recommend this to newborn nurseries who are constantly dealing with elevated abnormal CAH values in premature infants, and they're trying to make a determination whether this is a variant related to gestational age or a significant abnormality that might suggest we have a CAH that needs to be treated. The bottom line in situations, particularly in NICUs, is that it's important to follow serial results over time and look for the fall of greater than 100 as the baby gets older. Another option is to measure a more comprehensive CAH panel called a CHB panel in some of the well-known endocrine labs. Any steroid profile for premature infants is also available through these labs, and the costs run roughly about $395. These improve diagnostic capabilities, and all of them can provide age-specific, gestational-specific norms to help in interpreting complicated values. Another test that's frequently done, and this would be done in consultation with your pediatric endocrine specialist, is called an ACTH stimulation test, where we measure levels of the hormone precursors in a baby at baseline and 60 minutes after a dose of ACTH. It's sort of like a stress test to the adrenal gland where we bring out any blockade in the production of cortisol and mineralocorticoid. The cost of this test are close to $790, so it's not one of your beginning tests, but something that your subspecialty consultants may be recommended in interpreting middle-of-the-road or ambiguous values. Let's turn to some initial treatment goals for congenital adrenal hyperplasia due to 21-hydroxylase deficiency. In the classical salt-wasting CAH, we have a very sick baby presenting an adrenal crisis. We usually treat with hydrocortisone or Cortef, which is a solution, and it usually is prepared as a 2 milligram per ml solution or suspension. The dose that we usually use is between 15 and 20 milligrams per meter squared per day of hydrocortisone divided into 3 equal doses. Ideally, we want to spread that out Q8 to give adequate coverage to the baby throughout the 24-hour period. Another important consideration in handling infants with congenital adrenal hyperplasia is that because the adrenal gland naturally increases cortisol production during stress, it's important to triple dose infants during periods of stress. Stress is considered either fever greater than 101, an acute injury, illness, or even surgery. Under these conditions, the dose of hydrocortisone is tripled to cover the natural production of cortisol that the infant is unable to do because of their steroid block. Other initial treatment goals for children with congenital adrenal hyperplasia who are salt wasting is to include aldosterone, which is a mineral corticoid, to compensate for the salt loss. This is administered with fludrocortisone, which is a 0.1 milligram per ml solution. The standard starting dose is 0.05 milligrams PO BID. This will replace the mineralocorticoid deficiency that is leading to the acute salt wasting in the infant. Because infants are usually on formula or breast milk, their natural salt intake is very low. It can be less than a milliequivalent per kilo per day. Therefore, it's important, in order to have the benefit of the fludrocortisone therapy, to also supplement infants with a salt solution. We usually have the pharmacist prepare a solution of 1 to 3 milliequivalents per ml and then dose with sodium chloride at a total dose of 3 to 5 milliequivalents per kilo per day, divided every 3 hours to provide adequate salt to the infants to complement their fludrocortisone therapy. It's important to note that the long-term follow-up this has to be very close because some infants will be profound salt wasters in the first several months of life, and that this tendency will decrease or diminish over time, and so one must be attentive to the dosing to adjust it according to electrolyte values and their blood pressure values, because overtreatment can lead to hypertension. Another initial treatment goal to congenital adrenal hyperplasia is to realize that in infants, if they can't take their oral intake of Cortef, there has to be another emergency method to give acute steroid supplementation in case of adrenal crisis. This can be a real-world situation if an infant has an episode of vomiting and fever at home and is unable to take their triple-dose steroids by mouth. We teach all our patients how to give injectable Solu-Cortef in those circumstances, and the usual dose in an infant is between 25 and 50 milligrams IM times 1 in the event of adrenal crisis. We train all our patients to be calling our emergency on-call doctors, and we evaluate them in the emergency room if any situation where they have to give acute injectable Solu-Cortef. This can be life-saving to an infant who's on stable therapy, because in the absence of adequate cortisol, in the case of stress or fever, they can have hypotension and hypoglycemia, and it can be life-threatening. In the simple virulizing form of CAH, technically they have adequate mineralocorticoid and may not need fludrocortisone therapy. So largely therapy is based on hydrocortisone, again with a similar dose of 15 milligrams per meter squared per day. Even though we call these patients simple virulizing, evidence does support that they probably have a spectrum in their salt-wasting tendencies. And while these infants may not present, usually do not present with a salt-wasting crisis, they still have a slight mineralocorticoid deficit, and many of them do better long-term with low-dose fludrocortisone, even though we classify them as simple virulizing CAH. Again, we want to emphasize, even for the simple virulizing, triple-dose steroids are indicated for any episode of fever, injury, illness, or surgery. When we say triple-dose therapy, we do exactly that. Whatever the dose is, 3 times a day, we give 3 times of that, usually for 3 to 5 days or until the illness is over with. Injectable hydrocortisone treatment is identical in terms of treatment, 25 to 50 milligrams IM times 1. The family needs to be taught how to dispense and administer this in the case of an emergency at home. Other episodes where you might need to give injectable hydrocortisone would be episodes of repeated vomiting and diarrhea or unconsciousness. We teach the patients that they can do no harm if they give it in the case of unconsciousness, because it may be a manifestation of hypoglycemia in an infant, and that would be a case to give the injectable hydrocortisone.
All right, so we're going to talk now about a couple presentations in case studies for congenital hypothyroidism. We really want to just illustrate in these case studies that every patient is different and their presentations can vary. So our first case study is a female patient. She was full-term, normal birth weight. She was healthy other than some prolonged jaundice. She did require a 1-day readmission to the hospital for jaundice. Her family history was that she was the 3rd biological child of the mother and father, and there was no family history of thyroid abnormalities. So here's her presentation. Her initial screen was done at 1 day, 20 hours, which was perfect timing. TSH was greater than 400 with a low T4. So this was a definite red flag, and she was asked to come in to have serum labs done the same day that the newborn screen was received. So on her serum repeat, the TSH was 571 and the free T4 was 0.3, so this is a severe case. She was started on treatment at 9 days of life at 37.5 micrograms. She ended up having a repeat newborn screen that was done. In Alabama, this is just a recommended second newborn screen. At 14 days of age, her TSH was 52.2 and her T4 had normalized. So she did present with prolonged hyperbilirubinemia, and she had the elevated TSH on her second newborn screen. And so due to those things, we did increase her levothyroxine to 50 micrograms daily. And at her clinic visit when she was 3 weeks old, her TSH had normalized to 1.89, and the free T4 was elevated. And because of that elevation, we did decrease her to 44. So you can see that in the first couple weeks, there's a lot that's needed with as far as lab work and tinkering with the doses. We do often see that the free T4s become elevated as we decrease the TSH. And this usually will trend back down to normal over time. But with a free T4 that was that elevated, we wanted to go ahead and decrease because there's been a lot of evidence that shows that neurocognitive deficits can be seen from both over-treatment and under-treatment of congenital hypothyroidism. So it requires a lot of monitoring in the beginning. She did have a thyroid ultrasound done at 6 months of age that showed that she had no thyroid. So in this case, her diagnosis was based on her initial newborn screen. Her treatment was started at 9 days of life, which was within our goal of 2 weeks. And really, we kind of strive to have a goal of 10 days in our practice. So we did get her started in a good amount of time. The family was educated on the disease process and therapy. And in her case, therapy will be lifelong due to the absence of a thyroid gland. All right.
Okay, this is a case study 2, which brings in some features of diagnosis and the involvement of many healthcare providers, the primary care physician, us, and then the family social unit and how it impacts care. This is a Hispanic female infant who was 34 weeks gestational age. She was born at a birth weight of 2070 grams. Pregnancy was complicated by untreated gestational diabetes. This was mom's first pregnancy at 27 years of age. The infant was initially hospitalized in the NICU for 1 month due to the prematurity and some feeding difficulties. There was no family history of any thyroid disorders. The initial newborn screen was collected at 8 hours of life. This is standard protocol for a sick term infant entering any NICU. So on that initial screen, the TSH was greater than 400, with a normal initial screen should be less than 25. The T4 was highly suspicious because it was 1.8, which is very low compared to the normal range of 5.1 to 30. This is a red flag value, even though we know that this is within the first 24 hours of life, when we frequently see an artificial post-birth surge in TSH, the low free T4, and the magnitude of the elevation is highly suspicious for congenital hypothyroidism. The protocol would tell us to repeat the newborn screen, and that was done at 5 days of life. The unfortunate thing is that there was unsatisfactory specimen due most likely to inadequate or insufficient spotting on the filter card, making the interpretation of the results impossible. The good news was the screening lab was collected also at 5 days of age, which was the appropriate thing to do, and the diagnosis was confirmed by serology. They didn't wait for that filter card. What they found was the TSH at the time of testing was actually 640, with an upper limit of normal being 13, and the free T4, which is the most specific way of measuring thyroid hormone, was 0.14, with a normal range of 0.75 to 1.54. So you can see this baby is profoundly hypothyroid. I'm just going to go back for a minute. Obviously, at this point, the physician started a replacement thyroid hormone. We still got at 17 days another follow-up newborn screen, probably because that's the protocol in the newborn nursery. What it shows is what the child is on treatment, and you can see by 17 days of age, this TSH has come down to 34. It's not entirely normalized, but the good news is the T4 value, which is telling us about the actual blood level of thyroid hormone for this baby, was normalized at 14.8. And you can see that that's well within the range of 5 to 30. So we're very pleased if within 2 weeks we can normalize a thyroid hormone level in any baby who presents with that low of a value. So that's good news. At 31 days of age, another thyroid screen was done. And on this one, you can see that TSH was less than 3 or suppressed, and the T4 was slightly elevated at 13.7. Now, it's not quite clear why this one was done, but once it was obtained, in response to that, the thyroid hormone was discontinued. Prior to hospital discharge, an appointment was made with pediatric endocrinology, but the mom was unclear regarding the instructions and did not come for that appointment. The family's address changed from that listed on the newborn screen, and here is the plot where follow-up becomes very difficult sometimes in patients. An appointment was rescheduled, and the family was notified by letter and as phone, but the phone no longer worked. A care coordinator referral was placed, but the family no-showed for a second appointment. The primary care physician was able to see the patient in the interim and was the one who discontinued the thyroid hormone based on the third newborn screen, which suggested that the TSH was suppressed and was concerned that the baby was overtreated. Transportation needs were arranged for the patient to come to follow-up, but it was only by 3 months of age. On the initial appointment at pediatric endocrine, after all these efforts at 3 months of age, the TSH had again gone up to 133 because the baby had been taken off treatment. Free T4 was decreased to 0.48, which is low for this early sign, and thyroid ultrasound done at the time showed that the baby had no thyroid gland. Another test was done to look for detectable thyroid tissue, which is called thyroglobulin, and that was undetectable, again confirming what the ultrasound showed. It indicates that there was probably no other remnant thyroid tissue higher in the neck called a sublingual gland, and this baby was totally thyroid dependent. What we noticed on exam was that the anterior fontanelle was somewhat large. There was no jaundice, which can sometimes be seen. There was an umbilical hernia and some slight hypotonia and constipation by report. So we felt that this baby was slightly symptomatic. Our immediate response was to restart the levothyroxine at 37.5 micrograms daily and to provide education via an interpreter to the family and mother. Then from that point on, we followed monthly labs. One of the most valuable interventions we have in our pediatric endocrine clinic is that we can provide extensive education to families, breach cultural barriers, provide bilingual material, interpreters, and help people understand what the diagnosis is and what's going to be required of them in following on the care of this baby. I think when we looked back on this case, it was all inadvertent. There was a lack of understanding, and because education didn't take place earlier on due to the NICU stay, there was just cross-communication, and tragically, the baby went untreated for a period of time. Even though they were initially diagnosed at 5 days of age, the TSH normalized within weeks of treatment. They were lost to follow-up due to phone numbers being changed and addresses being changed. And this is a chronic problem, only one to get worse as things become more complicated. Very difficult often to track babies down and make sure that they maintain on treatment. Other issues were transportation, language barriers, and then the medication being stopped by the primary care physician. One thing that we encourage primary care physicians to do is we have a voicemail and direct contact to our nurse practitioner and physicians in children's. We'll provide you with some of those contacts, and we're always willing to discuss any case where there's a question of medication adjustment, laboratories, or interpretation to help anyone regarding the care of these babies with congenital hypothyroidism. So unfortunately, this baby went untreated for several weeks and actually had some mild clinical manifestations of hypothyroidism. Our goal in treating this disorder is to rapidly get treatment and to maintain and sustain normal thyroid levels throughout the first years of life, especially to give them the best chance for excellent neurocognitive outcome.
Okay. So our third case study goes from good to bad to worse. This is a term baby, normal birth weight. This was mom's fourth pregnancy at 20 years of age. So we know kind of just based on that, we're starting off kind of behind the 8 ball here. The baby was discharged home one day after birth. The family history was negative for thyroid problems in the mother, the father, and the half-siblings. So here's kind of her presentation. The initial newborn screen here was done at 1 day of age. The TSH was normal, 14.9, and the T4 was also normal. Due to some transportation issues, the second newborn screen was collected at 36 days of age. This was the baby's first visit to primary care physician after being discharged from the hospital. On the second newborn screen, the TSH was now 57 with a low T4. At the same day that we got those results back, we had the baby come back to the primary care physician. They had serum labs done as well as a repeat newborn screen. The serum labs at 44 days of age showed a TSH of 181 with a total T4 of 2.2, which was low. And the repeat newborn screen showed a TSH of 202.6 with a low T4. So in this case, the baby is clearly getting worse as time goes on. So for her, the diagnosis was based on the second newborn screen, and that's kind of been an area that's been debated. Is the second newborn screen valuable in congenital hypothyroidism? And we know it is. Treatment for this baby was initiated at 45 days of life, so she was a little bit later getting started because that initial newborn screen was normal. So education was actually provided from the primary care physician to the mom, and she was scheduled to follow up with us 4 weeks after initiation of treatment when the baby was 10 weeks of age. So here are her labs when she came to clinic. TSH was 215. The free T4 is still low. When we asked Mom about this, she said that she wasn't giving the medicine because she didn't believe that anything was wrong with the baby. So this is something we hear over and over with congenital hypothyroidism because it is silent until it is too late. So this is an area that we drive home with education that you do not always see signs or symptoms with congenital hypothyroidism. And so on review of systems, she had some constipation, physical exam, normal tone, no hernia, no jaundice. Her posterior fontanelle was closed and her anterior fontanelle was a normal size. This is something that we kind of look at for kind of to know how prolonged the hypothyroidism has been. So oftentimes, if hypothyroidism is prolonged for a very long time, you will see a enlarged posterior fontanelle. But in her case, her exam was pretty normal. So we provided more education while she was there in clinic, and we talked about the importance and drove home that you have to give this medicine, you have to follow labs. So we asked that labs be followed monthly, and we've tried multiple times to get in touch with the mom. The pediatrician has done the same thing. We haven't been able to get back in touch with her. And we do have social services and DHR involvement in this for possible medical neglect. So it's not really like the shining star for us to highlight her case, but it's important because we have to know that no matter how much education you give, some people still won't do this, and you have to pursue those channels of social services. So in her case, the diagnosis was delayed due to a late rise in the TSH, and treatment wasn't given due to perceived health of the baby. And we know that developmental delay is more likely in prolonged untreated hypothyroidism. Just a couple diagnostic pearls for congenital hypothyroidism. We know that repeat or second newborn screening can account for up to 12% of the diagnosed cases of primary congenital hypothyroidism. Serum, TSH, and free T4 are the diagnostic labs for congenital hypothyroidism. And if you ever have a question, we say just go ahead and get the TSH and free T4. Often we get the question, what's the total T4 versus free T4, and which do we get? The free T4 is believed to be the most accurate one, so we just recommend doing the TSH and the free T4. Recent research has shown that a TSH greater than 10 for over 2 to 3 weeks of age is diagnostic of congenital hypothyroidism regardless of free T4 levels. So that's one question we get over and over. The free T4 stays normal, stays normal, stays normal, but the TSH is elevated. When do you call it and treat it? Our practice is kind of moving towards the 2 to 3 weeks of age, regardless of free T4. If the TSH levels remain elevated, we think it's important to go ahead and treat that early. You can always decide to stop the therapy later when developmental delay is less of a risk, but you can't get back that time if you delay treatment. We know that parent education is critical, and it's important to provide education as early as possible on the importance of continuing therapy regardless of symptoms. And that's the last point, is that it's often silent, and parents just, no matter what, you have to kind of reinforce it. It's silent, you're not always going to see it, but treatment is so important.
And now we're going to change over to some case studies in congenital adrenal hyperplasia. The first case is a male patient who was born at 36 weeks of age, 2 days. The date of birth was November, and the birth weight was 2892 grams. The patient was hospitalized in the neonatal intensive care unit for the first 1 to 1.5 months of life because of some initial respiratory distress, poor perfusion, hypotension, and a cleft palate. During the course of their stay in the neonatal intensive care unit, the infant developed hyponatremia, hyperkalemia, elevated potassium, abnormal EEG, and prolonged hemodynamic instability. At that point in time, the family history was negative for any early pubertal disorders, short stature, adrenal gland problems, sudden infant death, infertility. And this was the first biologic child of both the mother and the father. There were 2 half-brothers biologically related to the father, but they were healthy and had no evidence of any adrenal problems. The newborn screening history is shown here. The initial newborn screen was sent on the first day of life, which is an appropriate move for a NICU for a sick preterm infant. And on that screen, the 17-hydroxyprogesterone level was 33.2 nanograms per ml, with the normal for that segment of less than 45 nanograms per ml. The repeat newborn screen was sent at approximately 9 days of age. That was 7 days of age, excuse me. And on that one, it was an unsatisfactory screen for multiple reasons, but this delayed diagnosis. The third newborn screen was sent on 12/18 at 18 days of age because of the unsaturated second screen. And surprise, surprise, the CAH screen was greater than 150 with a normal less than 25. So what you see is the 7-hydroxyprogesterone level, the CAH screen, is rising, which is very concerning instead of falling. Serum testing was promptly done using the CAH6 panel, was sent on the 18th due to continued clinical concern. And what they noted in this baby is stereotypic for a salt waster. There was hyponatremia, low sodium, hyperkalemia, high potassium, and hypotension. Very suspicious for salt wasting. the serum CAH6 screening would only be resulted in a week or so. So the recommendations, if we go back one slide, are that immediately in this constellation with a positive screen going up, a symptomatic baby who looks like they're salt wasting, send confirmatory serum testing, that's the CAH6, and start treatment, which is what they did. But let's look at the results of that test, which wouldn't have been available that day. And what they showed was that the 17-hydroxyprogesterone level by an outside lab was 39,200 nanograms per deciliter, or profoundly elevated in the salt wasting level for CAH. The cortisol level was undetectable. The testosterone level, which is the androgen that gets overproduced, one of them was very elevated at 255. And another precursor hormone called 17-hydroxypregnenolone was mid-range. I wouldn't worry about the last two precursors. The one that's clinically relevant is the first one, which is the 17-hydroxyprogesterone. That's what you're going to zero in on for making this diagnosis. And it's clearly markedly elevated, indicating a severe salt-wasting CAH. The serum electrolytes at this time was a sodium of 123. You can see the normal value of 134 to 143. These children waste profound amounts of salts and are hypotensive. The potassium wasn't that elevated. It was 5.6, but we frequently, if your child is presenting in salt wasting, you can see levels 9 and 10, and the kid can come in with ventricular fibrillation from that, so it can be quite severe. This is the nomogram that is classically used by endocrinologists to separate the different forms of CAH by serology, and you can see that based on the baseline 17-hydroxyprogesterone and a stimulated value, this child forms in the classical CAH value. That's no surprise because we saw that they were salt wasting, indicating that they have severe enzyme deficiency. Endocrinology was consulted by the NICU physician as soon as the CAH screen showed the elevated 17-hydroxyprogesterone, and hydrocortisone was started actually on day 20 of life. The child experienced prolonged hyponatremia after the introduction of this hydrocortisone, and fludcortisone was started on day 27 of life, which is a delay. I would have recommended early treatment. Not clear why there was such a delay with the salt wasting. At any rate, the sodium chloride supplements were also started on the 27th day of life, and the child experienced a rapid resolution of their salt wasting crisis. The karyotype on this baby was shown to be 46XY. This is an important test to do in these babies because, as we mentioned, the girls can be virilized. And just looking at the genitalia in infants who have severe congenital adrenal hyperplasia, one can be fooled by looking and think that an actual XX female is a male based on the outside anatomy. That's why karyotype testing is very helpful to confirm whether this is a male or a female. The initial endocrine evaluation was in January of the next year. The final diagnosis was clinical salt-wasting CAH. The plan was to continue treatment with the hydrocortisone, fludcortisone, and sodium chloride supplements. And obviously, genetic evaluation is very important. We involved the geneticists to test the actual CYP21-2A gene, and often in these cases there are large gene deletions. This is also important for further planning with other children because obviously both parents harbor a recessive gene and have a risk of other children being affected.
All right, so our second case study in CAH is a female patient. She was born at 36 weeks, 4 days gestational age. Her birth weight was 6 pounds 11 ounces, and her length was 18.75 inches. She was a well baby, hospitalized for 2 days following delivery. There was no family history of anything that would be concerning for adrenal disease. Her initial newborn screen was sent at 2 days of age and showed a normal 17-hydroxyprogesterone of 13.7. The repeat newborn screen was sent on 8/8, and if you go back, her date of birth was July 1st, so about a month of age. that was 39 days of age. The CAH level on this one was 66.1. So because that second one was abnormal, a third one was actually sent that showed the CAH now is greater than 150. So this is a huge red flag. These numbers should decrease over time, not increase. So we received the results of that second newborn screen at 58 days of age. The mom and the primary care physician were both notified of the results, and we actually evaluated that patient the next day in clinic. Her exam, she was a healthy appearing 2-month-old biracial female, the first child of the mother and father. She had no ambiguity, no concerns for clitoromegaly, and she had no history of illness. So in this case, things kind of look ambiguous. We have these labs that are increasing over time, and so we felt that the next best diagnostic evaluation would be to do the corticostin or ACTH stimulation testing. So her baseline 17-hydroxyprogesterone was around 1900 with a baseline cortisol of 2.3. She was given 125 micrograms of ACTH IM, and her 60-minute stimulated results, her 17-hydroxyprogesterone levels went up to 20,000 with a cortisol response of 11.2, which is marginal. Her electrolytes were normal with a normal sodium, and her potassium was also normal on the higher end. We also sent a study called the CAH-11, which is a urine study that also looks at the steroid ratios, and that she had increased steroid ratios that were suggestive of 21-hydroxylase deficiency. So if you look at her on the nomogram here, you can see that her baseline levels were around 1900 with the stimulated level around 20,000. So she kind of fell a little bit above the non-classic range, but we felt that just based on her clinical history of no illness and all that we would kind of consider her a non-classic CAH. She had no outward signs of CAH, and we knew that she could produce cortisol when stressed through this ACTH stim test, even though her response was, like we said, marginal. So our plan was to continue to follow her, at least closely, to make sure that she didn't go into any early puberty or have increased bone age. We wanted to plan to repeat the corticostin stim test in the future and wanted to send genetic testing when she got a little older. So lo and behold, we get the genetic testing a year later, and she has one gene with a large mutation called P30L and another gene with another large gene conversion referred to as the 30KB deletion. Therefore, she has a non-functional gene product with no normal copy of the CYP21A2 gene. So therefore, she actually is a classic simple virulizing CAH. And we felt that at that point, once we had the genetic information, that she did need to go ahead and be treated to prevent her having an adrenal crisis if she were to become stressed or very ill. So we went ahead and started her on hydrocortisone at 18 milligrams per meter squared per day, and we educated the family on stress dosing and the Salt-Cortef injection. So I'll let Dr. Mick talk about the diagnostic pearls.
Okay. So we have a few diagnostic pearls thinking back on our CAH case studies. The first one is when the repeat newborn screen is critical, and it's important to make the diagnosis of CAH using a serum, a 70-hydroxyprogesterone level. If you have a very high level, don't bother repeating the newborn screen. Simply go straight for serum, because that's going to give you the quickest, most accurate diagnosis, and that can be important and life-saving. If there's a concern of an abnormal screen in an otherwise stable premature baby, one can start with 70-hydroxyprogesterone levels and screen over time. If at any point in following either a term or premature infant there's concern of hypotension, hyponatremia, that's a low sodium, hyperkalemia, an elevated potassium, or there's ambiguous genitalia, you have to change your tactic and probably send the larger panel called the CH6B. If you're unsure about the diagnosis following an abnormal newborn screen in a stable infant with no other concern, the best thing to do is to call endocrinology, and we can set up to do our Kurtrosin stim testing. When you're dealing with premature infants, again, we want to emphasize to measure the 17-hydroxyprogesterone, and that level should decrease over time. Any evidence that that level is increasing over time as you follow these levels can be a red flag, an indication that we may be dealing with one of these in-between variants, which we presented in the third case. There will be patients with CAH that have the non-classical or mild form that are going to be missed by screening. That's understood that we can't pick up all the mild variants. That's the big debate. That may not be the role of newborn screening, something everybody talks about. We certainly want to get the children who are at risk for acute adrenal crisis and death. But these patients may be identified later in life. And then the other point is that the CAH6B panel can be a very helpful diagnostic tool to screen these patients, because there can be subtle variations, and it's going to give you more steroids in that panel.
Okay. So one of my roles in my position is to follow the long-term follow-up of these babies, and I want to talk just a little bit about the benefits and challenges of that. For congenital hypothyroidism, we know that up to 85% of our patients are going to remain on treatment for life, and in our experience, as many as 20% of those patients can be lost to follow-up within the first 3 years. We don't really know why that is. We kind of postulate that some obviously probably move out of state. We feel like some people kind of fall under that category of believing that it's not real and that it's nothing that needs to be treated. And so we've kind of moved our tactics a little bit with our education. We know that we need to make initial diagnosis education early, and we continue to review the importance of daily therapy and the importance of frequent lab monitoring. We've changed to sort of reduce stressing that some patients come off therapy. A lot of times that's something that a lot of people feel comforted by, that some patients do come off therapy at 3 years of age, but we try not to stress that in the beginning because we know it's important for them to be treated for the first 3 years. And we just encourage compliance with labs every 1 to 2 months for the first year of life. And again, research is moving towards more frequent lab monitoring in the first year of life because of the fact that either under or over treatment can cause developmental problems. We review the labs currently in our office every 4 months in the second year of life and every 6 months for the remainder of life after 2. It's important to encourage appointment compliance. Patients with congenital hypothyroidism need to be seen by an endocrinologist every 4 to 6 months for the remainder of therapy. And often we have frequent phone contact. Just make sure we maintain adequate phone numbers and contact information, and then just developing that rapport and continuing that over time with the families to help with any questions they may have during therapy. For CAH, treatment is lifelong and often multidisciplinary. Many of our patients with CAH, especially females, will be involved with surgical correction of genital ambiguity at some point. Often they need social services help and support. So we know that education is very important regarding the disease process, as well as therapy, which can often be very complicated. As Dr. Mick described, often these patients need medications as often as every 3 hours, and that can go on for the first year of life. We also have to provide education on stress dose teaching as well as Solu-Cortef injections. So, parents go from having a baby to all of a sudden your baby has this critical illness that has to be treated every 3 hours, and they basically become nurses at home. So oftentimes that takes a lot of support. We have to give them education regarding adrenal crisis, and we have to review that it's important to get consistent dosing and frequent lab monitoring. For lab monitoring in CAH, we monitor the 17-hydroxyprogesterone levels, sodium, potassium, and renin, and we do this frequently for the duration of therapy. They need to be seen by a pediatric endocrinologist every 3 to 6 months and can often need to be seen more frequently than that if they're having multiple procedures or surgeries done. These patients will need to transition to adult care at 18 years of age, and often the teenage years can be pretty tumultuous in their therapy with rebellion and that sort of thing. And so they need a lot more close contact once they get closer to that adult transition. We have to maintain contact with the families to answer any questions, and like I mentioned, support services become very important for these families. Often they'll seek out support through the CARES Foundation website, which we found to be very helpful for parents with children that have congenital adrenal hyperplasia. All right, so some frequently asked questions. We'll talk a little bit about this and hopefully can answer some questions. When do you do serum labs? If the newborn screen is abnormal, serum TSH and free T4 are diagnostic for congenital hypothyroidism. If you're questioning it, go ahead and get it. Just do it then and call us later. So if the TSH is elevated and the free T4 stays normal, what do? You can recheck this in a week or 2 weeks. If the trend continues, though, with an elevated TSH greater than 10, even in a normal free T4, go ahead and treat the baby, especially if that TSH remains elevated for more than 2 weeks. The safest thing is to go ahead and start treatment with levothyroxine. And if you send the serum labs and they have normal results, do you need to recheck them? Typically, no. We just would recommend that you follow your state newborn screening protocols as far as repeating the newborn screens. But the TSH and free T4 are diagnostic, so if you send those and those are normal, then we assume that the baby has normal thyroid function. We've already spoken about that. If you see a patient for congenital hypothyroidism that we also see and you're doing labs, should you alter the dose or would we alter the dose? In this case, we just would recommend that you just make sure that all serum labs that you do in your office, if we're following your same patient, get sent to us, and we'll make the dose changes. That way that kind of takes out that element of surprise when they come into clinic. But you can call our offices anytime if you have any clinical concerns or questions about the dose that your patient's on.
Okay, we're winding down here. Frequently asked questions for congenital adrenal hyperplasia. What should I do with an abnormal CAH levels in a premature infant? So in an otherwise stable premature baby, that's one without salt wasting, who's not hypotensive, no question of genital ambiguity, just send a serum 17-hydroxyprogesterone level. If it's elevated, feel free to contact our office because the normal ranges in preemies can be confusing, and we'd be delighted to help you interpret them. One of the most frequently things we're going to ask you to do if everything passes with discussion is to just simply follow trends every week or two to see what happens with that 17-hydroxyprogesterone level, and if it's an innocent elevation, it's going to trend down over time. So that's very valuable, and we're very happy to work with you by phone on all those complicated questions. Okay, should education be provided on stress dosing and Solu-Cortef before hospital discharge? Absolutely. Please call our office for educational materials. We have them on the web. We have a staff of nurses. If you're at Children's, we're always willing to come out and teach your patients so they know adequately how to inject Solu-Cortef. In the context of an emergency at home, it can save a child's life. If you can provide general information for parents, we will discuss this in more detail at the initial visit. So we just want to get them going. When is a cortrosine stim test indicated? When CAH levels are elevated in an otherwise stable full-term infant with normal sodium and potassium, this is a borderline result. Also, there can be borderline results in premature infants. Those would be indications to do that test. Feel free to call us. We'll get the child in. It's important to know if there is a mild variant and what to do, and we can do that as an outpatient in our clinic. Also, this might also be important, this test, if we have a young child who has early adrenarche, puberty, and there's a question of non-classical CAH. It also can be a presentation of polycystic ovarian syndrome. We've found some children, young teens, who we've made the diagnosis of non-classical CAH, and they've presented us like a classic polycystic ovarian syndrome. So there are ways to screen that, and the cortrosyn test helps us do that. And when should I send the CAH6B panel? If you're concerned about an infant with hyponatremia, hyperkalemia, hypotension, or ambiguous genitalia, that's probably the better panel to send as soon as possible, regardless, because you're going to get all the precursors. There are some, we've concentrated on the 21-hydroxylase deficiency, but there are some other enzyme deficiencies that can also be picked up with that. That would be the ideal case. In an emergency, if you can't remember anything else, the 7-hydroxyprogesterone will do us well.
Okay, so we're going to finish up today talking about a couple resources that we have through Children's of Alabama. We have parent education available online at our website, childrensal.org/newborn screening. There you can find our parents' guide for congenital hypothyroidism and a couple different resources for CAH, including the CARES Foundation website, which we find that parents really appreciate. Also, we can mail or fax any patient education materials either to the primary care physician office or to the patients directly. And we have consultation available, I say anytime, office hours, please, for any clinical questions or concerns. That first number there is my phone number. The second is our office phone number. And then there's our email address there, newbornscreening@peds.uab.edu. If a parent has questions prior to an appointment, or if social services are needed for an appointment, the parent can contact our offices. We have a social worker that is available to help them with transportation needs and things like that. We also encourage primary care physicians to ask families if social services will be needed, because we'd rather find that out before the appointment than after they miss the appointment, especially if it's something we can help them with. Currently, we're working to develop some video educational material for congenital hypothyroidism and CAH, including videos on stress dosing and Salt-Cortef injections. So we're hoping that hopefully within the next year we'll have those available, where we could also mail those out to families. Okay, thank you so much for your time.
Okay, that was wonderful. Thank you so much. Now's your opportunity to call in and ask the experts your questions. You can either call, hopefully the number's there at the bottom of your screen, or you can email your questions in. And I think to get us started off, I think I'll ask a couple of questions. When should, with either condition, when should a baby be seen in your office? If I'm a physician and we've already started treatment, we've had a consultation on the phone, when do you want to see them in your office? When is typical?
Typically, we like to schedule patients within a couple weeks of treatment being started. Obviously, oftentimes they're not always right in Birmingham, so there can be kind of some time for the family to adjust to, okay, we have this and now we have to travel. So we like to give them at least a week or two to kind of start the therapy, and then we'll plan to see them in clinic. That way they've been on treatment for a little while and we can repeat the labs at that time to make sure that the treatment is adequate. We do offer, once we've talked and a patient has started on therapy, we are available to the parent as well. So if they had any questions in that meantime before their initial appointment, they're welcome to call our offices.
Okay. Yeah, it's critical that therapy is begun, and that's where we love working with primary care docs to talk with them, get those initial screening labs, and get the child on treatment. But I agree, the sooner we can see them, it's not so much for therapy, we're following up on therapy, but also there's a lot of educational material. And as we look at the many cases we presented, a lot of time it's misinformation or inadequate information that has patients drift from care or not understand compliance. And those are so solvable if you start with a good grounding of education, which, you know, the visit can be over an hour or so, just going over material and getting people really oriented to what we're expecting and what they can expect, so that the whole care plan will unfold much more evenly and on schedule, and patients stay on therapy.
Well, it was interesting because with hypothyroidism, you were talking about it's silent. And so what are some of the things that you say as a part of your education to the family of, I'm looking at this baby appears normal. My mother and my grandmother say that nothing's wrong with this baby. So what are some of the things that you would say to parents?
We really try and stress the long-term effects of undertreatment. Luckily, I've never had any that have really pushed the issue too hard with me. I guess you could pull out that picture and just show them that over time it's not silent anymore. But most of the time we talk about just the fact that we know that development will be impacted if treatment isn't consistent, and just trying to reinforce that. And not everyone understands that, and not everyone follows up, but then that's where you kind of have to come in and say, you have to do this, and that's when DHR gets involved if they continue to not do that.
And the other tool in the education piece is we actually go over the exact labs, and the patient can see, you know, how abnormal the findings are, and sometimes that's very powerful when they may not see it in the child. They can understand that the thyroid gland really isn't working when they can actually hold and go over the actual abnormal labs.
When they were present with developmental delay for somebody that maybe has skipped treatment or it wasn't identified early, can you regain some of that developmental delay, or has the damage been done and there's really nothing that we can do but just prevent further delay from developing?
We do refer for early intervention type services in patients that do show developmental delay. That's part of our therapy, is to always be assessing the development as time goes on. And luckily, most of our patients that are on therapy have normal development. But if we do see developmental delay in a patient, you can't really go back and regain it, but you can intervene with some things that can help prevent further delay.
Does anybody in our studio audience have a question?
I have a question.
Okay.
Do these babies typically present with any other abnormalities?
For CAH or congenital hypothyroidism?
Congenital hyperthyroidism?
Sometimes you can see jaundice, sometimes you can see hernias, and sometimes heart defects. I know this year in particular, many of our babies that have congenital hypothyroidism have also had heart defects. So you can see a couple different things. It's not always the rule, but you can see other things associated.
Yeah, those cardiac babies often need close long-term follow-up because their hypothyroidism may not manifest until a month or two of life. So that's why repeat screening, those kids are targeted particularly.
Okay. Anybody else?
Well, I actually have a question. You have the one case study on the CAH. Now, I know with hypothyroidism that even a brief period without the treatment can, you know, cause the cognitive delay later on that you see. But with the CAH, the baby that was not started on treatment till coming into that first year, does that seem to cause any issues with the development for that in that particular scenario?
Well, insofar as this baby was in an intensive care unit, so was probably receiving intravenous sodium and chloride, and that's probably why they did well until the diagnosis was recognized. But any kind of hypotension, intravascular insufficiency is going to put a child at risk for perfusional defects, hypoxia, and in that sense. But in the standard case where we diagnose early and we begin therapy even before the child has had any hypotension, we're not seeing that. That would not be presumed to be the problem. We would avoid any episode. But that's a more complicated case simply because of the intensive care.
And then in the second case, with the simple virulizing that we at first thought was non-classical, we were following her for any sort of signs of early puberty or bone age advancement. So you can see that if you're not treating a non-classical CAH. And she's large for her age. I mean, she's tall, but other than that, no no early puberty, no signs of anything like that. And now a good question is, we don't know what would have happened to her if she had been very ill, or if she, say, had gotten in a car accident or something like that where she was injured and her body was stressed. So that's something that, you know, could potentially cause harm, I guess. But she was at least on our radar, so we knew that she had what we thought was non-classical, so at least if something had happened to her, hopefully that would have been passed on, that things weren't perfectly normal with her adrenal function, so maybe she would have gotten treatment.
And that brings out the fact that we categorize it as non-classical, simple virulizing and salt-wasting, just as a tool for discussing these patients. But the truth of the matter is this is an enzyme that's deficient on a continuum. And so there is a diagnostic blur. Not all patients will pigeonhole in one pot as always being this. There's a spectrum. And there's always an outlier. There's always patients who present who probably have fairly severe enzyme loss, and they've done fine, and they're presenting in infertility clinics or in dermatology clinics with acne, or maybe a little early puberty. But there's always a few variants where they can actually do well. We certainly don't want to take chances, and you know, with the knowledge of the real risk of salt wasting, we want to err in the favor of treating patients if we think their enzyme level is low. But it is really a continuum.
Okay, well, I think in the last 60 seconds or so that we have, because we know the whole point of doing this testing is really to prolong life. What is the prognosis for these children that have these conditions as far as life expectancy and health and productivity and being able to work and all those other things?
Well, we know in congenital hypothyroidism, as long as it's treated, neurodevelopmental outcomes seem to be perfectly normal. There's been some studies on that recently, but it's kind of hard to study what would happen if, treatment wasn't always perfect. But they grow up to be normal, productive, healthy members of society and can have children and work and all of these things.
Yeah. And with congenital adrenal hyperplasia, in terms of treating the adrenal deficiency and the salt wasting, we can do a wonderful job. One thing which we did not focus on, it's a whole lecture, is in the female patient who's been virilized and has genital anomalies. There's a long road. There's many challenges to the reproductive system, gender identity, there's surgery, there's a lot of it's a long walk, and so there is a whole team support to these patients. And so while life expectancy is good, barring, that they be good in their compliance, they also have many struggles and a whole subset of issues that relate to the virilization of the external genitalia.
Okay, well, thank you. I want to thank you for joining us. I think this has been a very interesting topic. I think it really lets us understand the importance of early detection and good testing of our babies. So, ladies, we thank you so much for what you do for Alabama's babies. And we want to thank you all for joining us here at the Alabama Public Health Television Network. And we'll see you next time.